Dave, you can't catch anything from us.
Afraid of a computer virus or something.
Yeah.
What'll happen is I'll get my car and start to hurt.
All right, let's get started.
So you're doing your job. 9 out of 10 times, actually.
I want to change the way we're doing this. It's not really working for either of us, I don't think. What I'm basically doing is reteaching the classes, and it's not what this is about. It's about revision, then prep, and I can't prep unless we've done some revision, which means I have to know what you need revising, and you're not really telling me. And I can't just do the whole class all over again. So this is what I'm going to do. Next week's session will be questions, answers, and discussions. All right. So I'm not going to prepare it. Well, I don't prepare anything anyway, but I'm not going to do anything, a formal lecture. I need questions from you. Now, you can either come up with the questions on the meeting, or you can chat, or you can ask me verbally, or you can email me stuff. You can talk about topics, you can ask me specific questions. I need to know what you need revising. And if you don't feel that you need anything revising, really, I haven't got anything to tell you. So that's what we'll do next week. And I think what I'll do is I'll do questions and answers one week, and then prepare something that you want me to do next week. So this week, you haven't had a chance to tell me what you need. So this week, I thought I'd talk about plantar fasciopathy, unless somebody wants something different. Does anybody? Okay. Let me just do this for next time then. I've got 5 topics up here, and you can come up with your own topics as well. If I can find it. Where the hell is it? Oh, there it is. Okay. So these are the 5 that I came up with, but you can certainly come up with others. Very happily come up with others. So it's clinical reasoning and diagnosis, serious ambulant injuries from MVAs, how to recognize them, non-traumatic MCL tears, how you get them, what to do about them, reflex inhibition versus segmental facilitation in general and specifics if you want, and tendinopathy, tendinitis, tendinosis, does it matter? Okay. So what I want you to do is pick the topic there that you would prefer me to talk about the week after next, or give me another topic. Okay. This is your session. It's not mine. I don't really need to talk about any of these for me. So it's entirely up to you. But I do need that from you. So do you have, I don't know if you've got my email. Let me put it on a chat. Let me get down to this. Okay. There you go. All right. So pick a topic there. I'll look at, and what I'll do is I'll rank them according to most popular down to the bottom, and I'll run through all of those unless you can come up with other ones. All right, and then I'm more than happy to do exactly that. Do you have any questions for me from previous sessions or anything come to that? No, okay, then this is pretty much the last time I'm going to do this. I'll pick the topic and I'll do it in a lecture format, sort of. And then after that, it's going to be you rather than me. So let's look at terminology first. Plantar fasciopathy, plantar fasciitis, plantar fasciosis. They're not interchangeable, and they are, certainly the last 2 are completely different from each other. Same tissue, but different pathologies. if I was to ask most people and said, how would you define plantar fasciitis, they would say that this is pain on resting with non-weight bearing for a period that is bad when you start weight bearing and walking, which gets better after a few steps or a few hundred steps. I think that's probably the way most people learn it at school, and it can't be true. It just can't be. Inflammation doesn't work like that. Inflammation gets worse the more stress you put onto it, not better. So clearly that's not plantar fasciitis, and the medical literature is starting to catch up to that idea. And there is more emphasis now on being more specific about terminology. So what you'll tend to find in more modern literature is the term plantar fasciopathy, which encompasses all pathologies to the plantar fascia. What we generally see, that description that you learned, isn't fasciitis, it's fasciosis. This is a degenerative fascia, not an inflamed one. And we can look at the causes of that, but generally speaking, it's over a prolonged period. Now, the exception to that is certainly with tendinitis and tendinosis, and this is probably still true of fasciitis and fasciosis, is that fasciosis can be the result of fasciitis converting into fasciosis and tendinitis converting into fasciosis over time. So it never completely heals properly. But what you're going to have there is somewhere in the past with these people is a history of an inflamed fascia, not a degenerative one. Now, it's the same thing with an inflamed tendon and inflamed fascia. You don't have to go pressing to find out where the tender spot is. You can almost rub your finger over the surface skin and they will scream at you. And fasciitis is either caused by fairly massive traumas where you actually tear the fascia, and it's really painful and it's very disabling, or it's caused by disease processes. And it's the same stuff that causes other enthesitis, rheumatoid, diabetes, gout, loads of different diseases will cause an enthesitis, which is what this is. So if you've got an enthesitis, what your treatment is going to be is anti-inflammatory once you find out that it's not a systemic disease. But what's interesting is I've only seen a couple of these recently, and I was using shockwave with treating these. And you can use shockwave on them, but it has to be very low intensity, and it has to be over a shorter period to start with, and then you can start increasing it. But you also have to do the anti-inflammatory stuff. And it's difficult to say which one works on it, to be honest with you. It may not be the shockwave that's doing it, it may just be the anti-inflammatories. But my understanding, mostly in the States now, you're not using shockwave therapy very much, which is unfortunate because it is useful. So your treatment for this is going to be rest, ice, ultrasound, so on, the anti-inflammatory treatments, and try and figure out why it's inflamed in the first place. So we're going to concentrate on the tendinopathy that is tendinosis, because this is the interesting one. Do me a favor, I want to get some interaction here, even if it's only with yourself, some action between yourselves. Can you find a piece of paper and a pencil or pen and just have it by you? And I don't want to see it, I don't want to hear about it, you don't have to tell me about it, but I want you to write down what you're thinking when I ask you a question, and then see if you've got it right or not. All right, now if you haven't got it right, according to me anyway, what you need to do at that point is ask me. You're missing something and you need to ask me. All right. Sorry? Good to hear. Oh, maybe that wasn't meant for me.
I think that's just Dave.
Okay. Yeah, just Dave. All right, so what we're looking for with a fasciosis or a tendinosis, come to that, is really long-term stress. This isn't, what happens is that the onset of pain isn't that whatever causes the onset of pain is a trigger rather than the cause. So I've already used the wrong word here when I use cause. It's really a trigger, and it turns something that's asymptomatic into a symptomatic problem. So we're looking for long-term stressors. So could you write down on your newly acquired piece of paper and pen 3 things that will stress this out? Now, the only thing I'm not going to allow you to do is use overuse. familiar overuse, all right? With tendinitis and fasciitis, overuse tends to cause tendinitis. Truly unfamiliar, severe overuse will cause tendinitis rather than tendinosis, and fasciitis rather than fasciosis. So you can write down anything you want, but familiar overuse, okay? I've already given you one, unfamiliar, severe overuse. So come up with two more things that are generic as well, fairly generic if you can, that will cause the tendinosis. It can take long. Okay. Thank you, Dave. Okay, so one of the things that will stress a fascia or a tendon is weakness. And the weakness can actually be in the tissue. So if we've got interrupted slow flow axoplasmic transportation, then you lose trophic nutrients to the tissue and the tissue becomes degenerate and weaker. Now, as to what causes axoplasmic flow disruptions, it's mechanical compression, torsion, kinking, traction, but it's a mechanical effect on the nerve. Now, the compression can be at the spinal nerve or spinal nerve root, so you'd have a radicular distribution of this, or it can be in the peripheral nerve, or it can be in the terminal nerves. So anywhere along that line. And then it gets complicated by the fact that you can have multiple areas of block, where a single block isn't enough to disturb the flow. So I can have a subclinical problem in the spinal nerve, osteophyte, small disc protrusion, something like that, but it's being compressed there. But that in itself wouldn't be enough to give you clinical findings. And then I have another one down by the elbow, for example, hitting the ulnar nerve, or anywhere in the terminal carpal tunnel. I can have a compression more distal, and the two of them can summate and start giving you clinical findings. Now, this is called double crush or multiple crush syndromes. And the symptoms show up distal to the distal block. So you can't talk about axoplasmic flow having a definite distribution of findings. Now, if the axoplasmic flow is disturbed more easily than its electrical conduction, so it doesn't take much to disturb the protein flow through the core of the nerve. If I have enough blockage, then I'll have multiple signs of that axoplasmic flow loss. Generally speaking, though, with minor amounts, which are subclinical, all you'll find is weakness. If it's a clinical block, then you're going to have paresthesia and perhaps other symptoms. But if it's subclinical, the only thing that's going to be found is weakness. Anything more, giving you more than weakness, you really want to start thinking about these being a neuropathy or a radiculopathy rather than an axoplasmic flow loss. So I think it's fair to say that for what we're talking about, that is failure of the plantar fascia. The axoplasmic flow contribution will be subclinical. Otherwise, it's going to be a whole problem on its own. So we're looking for weakness both in the tissue from slow flow interruption and in the muscles from fast flow interruption, because that fast flow provides replacement vesicles to the synapses. So you get synaptic failure as they get starved of these replacement vesicles. You cannot find evidence of slow flow loss. There's no way you can see it. You just can't see it. It's degeneration inside a tissue and you can't see it. But it's reasonable to assume that if fast flow loss is lost, then so is slow flow. So what you look for is loss of slow flow, and you look for weakness there. So if I've got weakness in the intrinsic muscles, In the plantar fascia, it's going to lose support. The foot's going to flatten out. It's going to be chronically stretched, especially during locomotion. It's going to be chronically stretched, and it can break given that. Does that make sense? Again, if there's no response, I'm going to assume it does. It's a crappy assumption on my part, but I can't make any other assumption. All right. So this is one of the causes of chronic stressing of the plantar fascia: muscular weakness, support weakness. Now, the foot can flatten out as well without that muscular weakness. And we talked a little bit about it last time with the long leg. With a long leg, the foot will flatten, and it's not doing it because it's trying to shorten the leg. We tend to anthropomorphize this. It's flattening because the forces are forcing it to flatten. Ground reaction force, body weight, the leg twists medially, the foot flattens out. But that flattening is occurring in spite of the muscles. So the muscles now are taking more strain, but still, foot still over flattens. What we talked about last week is that you may need a second contributor, and you usually do. You need either a second cause or contributors that allow that over flattening. So the muscles basically cannot control it. So the foot over flattens, and again, the plantar fascia gets stretched. Is that okay? So if we find, what we obviously need to do is, there's no point in going over last week's talk on long leg, but if we find weakness, or we're looking for weakness, you can certainly look for weakness throughout the whole of S1, S2 segment that's going to innervate the foot muscles. But the chances are this is not that big. If I've got a block at S1, S2, compressing the nerve enough to give me axoplasmic flow loss, that's a hell of a compression. It's more likely to be a double craft syndrome. And that flow loss can be occurring further down the chain. And it can be under the medial arch. If the medial arch is collapsing for one reason or another, then it can get caught going around the... Dave, you got in with that at the waiting room, didn't you?
Sorry?
Without going in the waiting room, didn't you?
Yeah, I went directly to the site and I typed in the user or their meeting name, and I typed in the password, and that brings you directly in. Otherwise, you have to sit in the waiting room.
Yeah, I've disabled the waiting room. Who was that who just come in? That's it. Who just came in? Maybe they didn't. I disabled the waiting room, so I'm hoping they can get in that way. Anyway, so you have to test the strength of, that's got to be your first test. You've got to test the strength of the intrinsics of the foot. And that is very rarely done. It's never taught, but that's got to be the first place you test it. If the intrinsics are strong and repeatedly strong, then you don't have an axoplasmic flow problem, giving you fatigable weakness, because you don't have weakness. Okay, but that's got to be your first area of testing, and it's got to be repeated, because axoplasmic flow weakness, force output weakness now, is very fatigable, because what's happening is the synapse is repeatedly having to be fired across, the vesicles are being released, and they're not all being resolved. Some of them are getting lost, and it's that loss of replenishment that causes a weakness. So it may take quite a few repetitions or a sustained contraction to see that, but you've got to test for it if you're thinking etiology on the plantar fascia. Is that okay? So make sure you do test the intrinsics. It's no good just looking at the foot and seeing if it's flat. That doesn't tell you whether the intrinsics are strong or not. You don't know that the intrinsics are weak just because the foot is flat. So you have to directly test the strength there. Now, having found that that they do have fatigable weakness in the foot and nowhere else, then the question arises: this obviously isn't part of a radicular problem. You can check it. You have to check around to see what could be causing that in the foot. So where would the nerve be blocked? But you can do some other tests. You can do Tinel's. Well, if it's other areas, you can do position tests. You can do upper limb tension tests, which may, if you're really lucky, stress out at the nerve enough that you'll get paresthesia when you do it. This is where, for me, the real value of upper limb tension tests is concerned. But you can do a straight leg raise here with dorsiflexion of the ankle and so on, and seeing if you can reproduce, not pain now, but paresthesia. But what you may have to do is go up and test muscle groups within the peripheral nerve and then the radicular distribution to see if you can figure out exactly where this problem lies. And then you have to correct them one by one and look at the changes. But the change in the strength should improve as soon as you take the pressure off of the most peripheral part of that nerve. Is that okay? Now, what you could obviously have is a combination of two things. If I've got a long leg that is flattening the foot, then it's going to cause the whole leg to immediately rotate, and that can overstretch a nerve in the foot. Now, if I've got a crush somewhere else, a block point somewhere else, that may in itself be enough to cause symptoms distal to that last blockage. So the long leg actually acts on the nerve to give you a double or multiple crush syndrome. Is that okay? Who dat? Somebody just come in?
I did.
Okay. So no waiting room for you.
What's that?
You don't have to go through a waiting room?
I did not.
Hey, done it. Found it. Okay. So next week, I'll try to remember to disable the waiting room. You can just come in. Okay. May not be here, but you can just come in. All right, so where are we now? Does that pretty much coincide with what you understand about plantar fasciopathy and plantar fasciosis?
I have a quick question. You talked about like the weakness and the long leg and whatnot. What about different mobilities? So like if you have
He died on me.
Either she's thinking real hard or she's frozen.
Yeah, she has, isn't she? Everybody else is all right, so it's not me. That's the main thing.
Yeah.
there we go.
Okay.
Okay.
Yes. And she's back.
Could like a mobility restriction cause, like over time, cause that to become more of a fasciopathy as well?
Where are you thinking?
So I'm thinking like the first ray causing increased stress on those intrinsic muscles or anything.
Yeah, I mean, if we look at all the causes of this, the plantar fascia in weight bearing is supposed to be under a fairly constant tension, whether you're up on your toes or flat on your foot, as long as you're bearing weight, like full weight through the foot. So when you're in foot flat, the heel's going laterally and the forefoot's going medially, yeah? So you're getting that twist, reverse twist. Now, if your foot can't do that and flatten out, then the chances are what you're going to get then, you won't get increased tension on it, but you'll get a twist in it if it can't flatten out. Let's say the heel is subluxed into inversion, that's probably the easiest one. It's subluxed into inversion, it can't go valgus. It means that when you're at full flat, you're not going to apply maximum tension to the fascia because you need eversion for that to occur. But what it is because you do see this with inversion injuries, inversion and eversion subluxations, both can cause plantar fasciosis. But if it's twisted in, it puts an abnormal torque through. So it's going to tighten up some of the fascia, some of the tissue in the fascia that it shouldn't do. So that can break it down as well. The same thing applies there. If this is stuck in eversion, you've got a prolonged stress on it. And that'll do it, yeah. Same with the big toe. The big toe, if the big toe can't extend, it means that essentially the leg's going to be longer than it should be. Now that's in toe off. So the effect of that is probably a lot less than if it was something that was occurring in full flat foot, where the maximum tension is in it. But what will happen is, and we didn't talk about this with weakness of the foot, because I stopped axoplasmic flow. Reflex inhibition will cause weakness in the intrinsic muscles. So for that to occur, the inhibition has to be in the foot. Obviously, it's got to be something over which those muscles run. So it's got to be in the foot for intrinsic weakness. So yeah, that could be the toe, it could be the arches, it could be the hind foot, it could be anywhere in the foot to give you that reflex inhibition. Yeah, and you can often just manipulating the everted, that's the easiest one to talk about. The everted calcaneum is enough to take enough stress off of the fascia so it stops being painful. You haven't done anything for the degeneration, but you've taken the stress off it so it's no longer painful. Is that okay? If we come up the top, you can get an episodic radiculopathy. It comes and it goes. And probably what that is, and you see it a bit more in the neck than you do elsewhere, but it's probably what that is you've got a subclinical stenosis of the transverse foramen, and then have an extension subluxation on top of that, and that closes it down enough not to necessarily give you an overt radiculopathy, but it could cause something like axoplasmic flow problems, or it could cause a minor radiculopathy where the only things you're seeing is not so much symptoms but signs, and the local symptom may be back pain, because you haven't got enough pressure on the dura to give you leg pain, but you may find signs of it, and it may even be paresthesia as the nerve gets compressed. So yeah, joint hypomobility is a big one. So if we go back, sorry, I got caught up on something there. We talked about weakness of the intrinsics from axoplasmic flow. I've just talked about reflex inhibition doing it. The other neurophysiological problem is going to be segmental facilitation. So, all right, now I'm going to give you this and you can take it or leave it and we can discuss it. I would like to discuss it. Typically, segmental facilitation, the cause of it is given as prolonged aberrant input into the segment. But that can't be true, because if I have prolonged aberrant proprioception, that doesn't give me segmental facilitation. It gives me reflex inhibition. I think segmental facilitation is caused by prolonged nociception, not necessarily pain. In fact, definitely not necessarily pain, but nociception. And I'm making that point because I need to make the next one. The cause of the facilitation can come from any nociceptive structure within being innervated by that segment. Is that okay? Now, the same, it's no different from the statement saying that segmental facilitation can be caused by any prolonged aberrant input into that segment. I'm just being a little bit more specific when I'm saying it's nociception. Now, where that is a whole different matter. Now, if we're looking at plantar fasciosis, you've got pain in the foot, pain in the tissues derived from that segment, that in itself will give you, or should give you, if it's long enough, segmental facilitation. So you would expect to find evidence of segmental facilitation with plantar fasciosis, but it may not be the cause of the plantar fasciosis, but the effect of the fasciosis. Is that okay? So what you've got to try and do is decide whether it's cause or whether it's effect. Now, I can't do that for the plantar fascia. I have to assume that's an effect. But is there another cause of facilitation? So what I need to now do is see if I can convert nociception to pain. So that means doing screening tests, in this case, everywhere in L5, S1 area, and see if I can provoke pain, abnormal pain, preferably on that side. So I've got all sorts of tests I can do. That I can do PAs, I can do unilateral PAs, I can do quadrant testing throughout the lower leg. I can simply find different ways of stressing each of the joints. I can palpate for abnormal tenderness throughout that segment. But what I'm looking to see if I can provoke pain, if I can provoke abnormal asymmetrical pain, the chances are there was nociception there before, and that area now is worth investigating for probably a segmental dysfunction, but some form of dysfunction that doesn't reach the pain level but is nociceptive. Does that make sense? So what typically happens, as far as my experience is concerned, is locally, where you have joint dysfunction, joint movement dysfunction, locally you'll find local evidence of reflex inhibition. Over the entire segment, I may well find signs of segmental facilitation. So I'll find hyporeflexia and braking weakness locally, and brisker reflexes, if I've got any changes in those reflexes at all, brisker tone and non-fatigable weakness throughout the segment, plus a scratch reflex test. Now, this is often what happens. You're going to get two things going on at the same time. So the hypomobile joint, particularly if it's not painful, will give you reflex inhibition, braking weakness in particular. Nociception and pain elsewhere will give you segmental facilitation. With something like plantar fasciosis, if I've got plantar fasciosis and I also find reflex inhibition throughout the foot, as opposed to segmental facilitation, I guess, then my treatment of the joint that's causing the fasciosis should get rid of the reflex inhibition, but not necessarily get rid of the segmental facilitation, because that may be coming from a different joint. Is that okay?
So in this model, if you have an everted calcaneus driving the reflex inhibition, then the manipulation or correcting the everted calcaneus should resolve the muscle strain. So if I go and retest the muscles, all the muscles then would be somewhat normal. It wouldn't be
Yeah, it should be. Yes.
But if I have reflex inhibition,
But it may convert now to basically into a segmental facilitated weakness.
okay.
Yeah, it's not that the segmental facilitation isn't present in the foot, it's just dominated by the reflex inhibition.
Okay, so you could still have residual segmental one, but then that would be more related to a neurological segment, say L5, S1.
No, not necessarily. No, that could be coming from the knee. I could have a Baker's cyst that will cause a segmental facilitation.
Okay.
Yeah, the cause of it doesn't have to be in the spine. It's a sort of an unfortunate term because you immediately go to the spine, but the cause, the nociception could be anywhere within L5, S1. Yeah. Of course, you've got to remember that the weakness in the foot intrinsics may have been what allowed the subluxation of the calcaneum in the first place.
Yes.
Yeah. This is where the stuff gets really interesting. Making a diagnosis is relatively easy. The rest of this stuff isn't.
I think the difficulty some people have sometimes, Jim, when they're thinking about the potential for a peripheral structure to cause a segmental facilitation is that when you're looking at a particular joint, actually all of the lower extremity joints have more than one spinal level crossing them.
Yeah.
So having, a Baker's cyst in the knee, you're going to have 3, 4, 5 at least.
Yeah, but the back of the knee is predominantly supplied by L5, S1.
Correct.
Yeah, so it's got to be a matter of summation. Has to be. The segment that is most involved in that tissue that's painful or nociceptive has to be the one that provides the segmental facilitation.
Agreed. Yeah, I think that's totally true. It's hard when you start thinking about potentially like a chronically inflamed joint, a sprained knee that doesn't heal properly, something like that, because now you're looking at the entire joint.
Yeah, but it's interesting. Even there, if you take a a chronically inflamed knee, the pain is almost always on the medial side.
True.
Yeah. So even the joints, the shoulders here, isn't it? Rather than under here. So even joints, when you've got a global effect on the joint, it still is preferentially going to one or two segments. I have no idea why. I mean, this is neurophysiology, and my neurophysiology isn't deep enough for that. But it does look as if, well, they are, these joints. Every joint is supplied by every nerve that runs over them. Yeah, what's that, Sherrington's law, isn't it? But obviously some nerves have a lot more input into the segment. That's the way it seems to pick out. But it's got to be where the pain is. The tissue that is painful has to be the one that's generating the facilitation.
Yep.
And that's the other reason I don't think this is about simply aberrant input. I don't think nociception has anything to really do with facilitation.
You mean proprioception?
Proprioception. So I say no, proprioception, yeah.
Yeah. Yeah, I would tend to agree. I think proprioception tends to be a little slow for that sort of thing, just because the joint has to already have moved for it to create any type of feedback. So I would agree with the nociceptive thing.
Yeah.
Could you?
As I say, every nociceptive dysfunction I know produces reflex inhibition rather than proprioceptive dysfunction I know produces reflex inhibition rather than segmental facilitation.
Certainly. Could you real quick? I know Gail champions this a lot, and I know I tend to teach it on some of the courses that I do, but the idea of velocity-dependent weakness with segmental facilitation. I know you've had your doubts about that in the past, so I was just curious if you've had any other thoughts on that.
I'm not sure that it doesn't have a complication that is necessary. For me, well, actually, that's not true. If I'm looking at reflex inhibition, I don't think you can, I haven't been able to find that in big muscles without doing an eccentric contraction from the end of range. So the muscle is pretty good, providing you're doing it in a stable position. As soon as you move it into an end range position where it's less stable, then you see the weakness. So I think that's about stability of base. I think if you've got an instability in the mid-range, that instability doesn't show itself at the ends of the range, then it does. Now, what I see there when I find that is you get an initial give, and then it strengthens, and then it breaks as you go through the eccentric. And that initial give, I'm pretty sure, I've never done it, but I'm pretty sure if you pushed on that hard and fast, then you get a break all the way through. But if you push on it gently, you'll get the break, it'll be weak and give, and then it'll tighten up again. So that's maybe the basis of it. If you push on this fast enough, it doesn't get a chance to stabilize in the way it goes.
Sure. When I've talked with Gail about it, one of the excuses we've come up with, and I call it an excuse because we don't have any proof, is that the idea of facilitation causing of speed-dependent weakness is due to the increased tension across the muscle belly, so the hypertonicity that develops, and then the speed dependence of the resistance causing a reflex reaction of the GTO that gives out the muscle. It's more of a self-protective mechanism for the structure there.
I would expect that to give you a breaking weakness. So. Yeah, I mean, there's nothing wrong with explanations at all. I mean, speculation's fine. Because what you're doing is you're generating a model, and models don't have to be true. There is no need for a model to be true. It just has to explain the facts. And as more information comes in, the model gets stronger, it gets weaker, and you just throw it out and modify it.
Yeah, it's just something that I see a lot clinically. You know, and we're looking at like some criterion validity on what, you know, why we're seeing what we're seeing, that sort of thing. So I was just curious what your thoughts were on that.
Yeah, so I think you've got enough for me to differentiate facilitation from reflex inhibition. It's a type of weakness, so non-fatigable versus breaking weakness. It's where I find them. Eccentric contraction, it has to be an eccentric contraction to be clearly delineated as reflex inhibition. That's not true of of yeah, and the patterning. Reflex inhibition is patterned around a joint, so you see P and F type patterns around the joint. Looking for tone changes and reflex changes is really can be very, very difficult because they're quite subtle, those changes. So they're added bonus. If I find those as well, then it gets added in. If I don't find them, I ignore them. So the big thing for me is the quality of the weakness, the patterning of the weakness, and the distribution of the weakness. And then scratch. The other one is scratch reflex along the spine. That pretty much has to be there.
Yeah, and that's one of those things that's almost tough to learn how to do too, because you have to look at it real quick because it kind of comes and goes very quickly.
Yeah, it's got to be done quick. For me, the more obvious signs are the best signs.
Yeah, I agree. Yeah, and the peripheral versus segmental distribution is probably the number one thing that you have to look for, especially if it's non-fatiguing. But
I think to say segmental facilitation, you've got to say you've got evidence of it distributed throughout the whole segment. And then the last thing is wobbling. Like if you wobble low, let's say I've got we'll go back to the plantar fascia. If I've got weakness in the intrinsics, and that's due to segmental facilitation, because I can't tell the difference in this particular case of reflex inhibition of segmental facilitation, then I'll do PAs on the spine. If it clears the foot up, then that was obviously facilitated. Can't really be anything else.
yeah, you change the spine and you change the foot. Clearly, the spine is affecting the foot.
So the first wobble is always done away from the symptomatic area. Yeah, if it's a spinal problem, and I was thinking that segmental facilitation may have caused that, I'd be wobbling somewhere down in the knee or the ankle or somewhere.
Yeah, I was just going to say, if the spinal wobble, the spinal PAs don't give you the result you want, you go and check the local segment around the local joint and see if the wobble works.
And often what you'll find there is not facilitation, you'll find reflex inhibition, you'll find hypotonicity of the multifidus and trunk weakness, breaking trunk weakness.
Right, but you can certainly see an underlying facilitation underneath that reflex inhibition.
Well, you find the other side of it. You find the scratch reflex is there, and then you find the distribution throughout the rest of the segment. Yeah. But locally, I think more often than not, reflex inhibition dominates the picture.
Agreed.
I think if you've got a lot of pain, then from that area, then that dominates the picture. But it's got to be a lot of pain. Then chances are it's not a segmental dysfunction anyway. Yeah. How are we doing with this, guys? How are we doing with time? Okay.
I think in context, the most common thing now you see is, okay, is a motor pattern is functioning, and how this overlaps with motor pattern is functioning. When you're looking at your typical patient that you've seen before, and it's like, these are the things you're looking for now, where you think, okay, this person has a motor pattern impairment or something's off. As Jim said, it's okay, are they weak intrinsics or are they inhibited intrinsics? And then the patterning is off because of that. And so it's all ties back around. This layers into what is popular and what is in vogue. It's that next layer on look at the neurophys of that segment. We're using reflex inhibition, segmental facilitation, and then coming back after you've done all that to say, okay, how can I change the motor patterning?
Yeah.
It's kind of current what you see in Achilles rehab, where this group in Australia is doing more and it's like neurodynamic training they do now, because they were seeing that, okay, with transcranial electrical stimulation, they're watching the brain and seeing that with the Achilles, that even at the cortical level, the firing pattern these chronic Achilles patients was off, and that you had to basically retrain some of the firing patterns cortically in these individuals to kind of get this to go. So you have these other layers that are involved in there. So that motor pattern retraining portion at any level also has relevance in this.
It's amazing how orthopedics is trying to reinvent neurology.
Yeah.
It's only neuro. Well, I say it's only neuro. It's one of the reasons I wouldn't have got into physiotherapy. If I had to do neuro, I would never have come into physio. It's too bloody difficult and it's too boring. And it's too necessary as well. I like stuff that's not absolutely necessary. So what about treating locally? One of the favorite treatments, I guess, is the stretch of plantar fascia, and I've never understood that. It will get rid of the pain, but the plantar fascia is the major ligament in the foot. Now, this is like having a medial collateral chronic injury to the ligament there. So you've got a chronic grade 2 tear, and then stretching it out so that it doesn't get stressed anymore. What's happened to the stability here? To me, this, I mean, you might just well inject it, let the bleeding ligament rupture, and you're done. Why wouldn't you do that instead of stretching the bloody thing out? So it doesn't make a lot of sense to me. I don't think ultrasound is utilized enough, to be honest with you, even with non-inflamed conditions. You can get a lot of heat generated by ultrasound, and you can get a lot of mechanical stress in there as well. The problem is that almost nobody uses ultrasound in high enough doses for any of this stuff. The way I use it is, it's either unpulsed, and I'll move it slightly when they start to feel it, or it's pulsed, put up high and held still. And it's always to the patient's tolerance. So I'll turn it down as I need to, but I don't rub it around, and I leave it where it is. And they'll get maybe 10 minutes of ultrasound. And that does work. That actually does work on a variety of different problems. I can't see any reason why it wouldn't be used on the plantar fascia. No reason at all. And of course, the other one is shockwave. It's a bit deep for frictions, but if you can do both of those things, give them some support so they're not constantly stretching it and hurting themselves, and then deal with the causes of it, I think you haven't got too far to go. So let me backpedal a little bit. I asked you about the causes of this and said that weakness was definitely one of them, both structurally and muscularly. Prolonged overuse, and I said you can't use that, but you can, providing it's internal overuse. So if the fascia is continuously being abnormally overstretched, that is prolonged overuse. But it's very direct. It's not like you're doing the same job for 10 years and then breaking down. Something's intervened in there to break it down for you. So the predisposition is there because what you've been doing is setting up a degeneration, and then something triggers it to become symptomatic. So in this case, it's much the same thing. You're getting degeneration caused by prolonged stressing, and then something will break it down. Disease. Don't forget disease. Disease will degenerate collagen, or at least collagenous diseases would degenerate collagen. So this is personal now. I used to backpack, not often, but I used to backpack into the Rocky Mountains, and I can never pack a backpack. It was £70 if I was going overnight or going for a week. It's always the same bloody weight. And I got in for camping, and I was put the tent up, sat back, I brought a bottle of red wine with me, drank that, and woke up in the morning with plantar fasciopathy. And this did not go away. I had to limp out of there. It was about an 8-mile hike downhill now. And it was painful every stretch of the way, and the bloody thing didn't get better and didn't get better. And that was my first bout of gout. Yeah. So it really had nothing to do with the mountain. I've talked to people, I've given this story. Well, which way round the mountain was he going down? I mean, seriously. You're constantly trying to find mechanical causes for things that may not be mechanical. And tendonitis in particular, and fasciitis in particular, may well not be mechanical, they may be medical. So your first thought with something as abnormal as tendonitis, which is a very abnormal condition, and fasciitis, which is an abnormal condition for us, should be medical, and then rule that out as much as you can before you get on to the other stuff. Tendinosis, no, but or fasciosis, no, but tendonitis and fasciitis, you really should be thinking medical conditions beforehand.
Yeah, red wine's actually one of those big triggers for that.
Yep, purine. Yeah.
Mm-hmm.
Yeah, peanuts, red wine, and Guinness. I was going to give up life at that point.
It's the end of that.
Yeah, no point anymore. Can't drink Guinness, can't drink, actually liquor, generally liquor, but Guinness in particular, and peanuts. What the hell's the point in life? All right, guys. So, as I said, I need you to pick a topic. All right. Don't care which one, just pick one. And next, or pick your own, by all means. And then next weekend or next week, we'll do questions and answers. All right. So email them questions. You'll put them on chat if you don't want to say it verbally, or you can ask me at the session. All right. I don't mind. But if you're more comfortable with emailing me, you've got my email address, and we'll do that. It's amazing how much you can get out of that. What I do on classes is on the Sundays of every weekend, I'll tell them they have to come up with 2 questions each, just in case somebody comes up with the same first question. But everybody has to ask a question on that Sunday. And basically, it's amazing where those conversations go. Really worthwhile. So put some effort into this and do it. Okay, guys? Any questions before we quit? All right. Okay, I'll talk to you next week.
I did want to know,
Yeah.
I just typed it in there about how long these weekly Zoom sessions are going to be planned out so that I can block the schedule. When
Yeah,
these
we'll
are-
keep going until at least until your first weekend course.
Okay.
All right.
And then where are the recordings getting put?
Sorry.
The recordings of each session, where will they be?
No, I've sent them to you.
I think Travis sent them.
Hey? Yeah, I sent them off to
Travis-
Travis. Travis gets them. You have not got them?
No, that I know the first one that you guys did after the session, since we
No,
forgot. to put
I know the first one that you guys did after the session is we forgot to put.
I don't know. You've had one from me every time, haven't you, Dave? Because I send them on. I don't send them to you, do I?
I don't know. You've had one from me every time I because it's similar.
Sorry, say again. I couldn't hear you.
We're getting
Say again. I couldn't hear you.
Can you hear me okay?
Yeah, I can hear you.
Okay. Yeah, I thought you said them like Travis and I. So what I can do if you want to, I can go to the site and post them, then email them out. Because I believe there's 2 of them so far. I'll pull them out and email them.
Well, there should be 4, shouldn't there?
I'll take a look.
5, because I actually did an add-on to the first one, didn't I? Where I forgot to record it. Or last one, was it? I don't know, first one.
4. Yeah, you have 2 from the one session and 3.
Yeah.
So yeah. Okay. I'll go.
All right.
I'll try and pull them and have a spot to post them and email them to you.
Okay. Yeah, I'm sending them off to Travis, so I don't know. But I'll do the same with this one, because I haven't got your email addresses.
Mm-hmm.
I've got them all. If you need me to send them out, I could do that too.
All right. Well, I'll send them to you. All right. Well, I'll send them to you and Travis then.
And Jim, what is your email? I don't know that I got that, but I.
It is.
It's on the chat.
It's on the chat.
She might have jumped in after it came up.
Yeah,
though.
she did.
Yeah.
Let me give it to you here so you don't. Where is it? Here we go. I'll do it again.
Katie was running late, so got to
Yeah.
redo everything for her.
Yeah, yeah,
So I really appreciate you repeating yourself. Thank you very much.
Okay. Anything else, guys?
Nope.
All righty. Okay, have a good week.
All right, you guys as
Talk to you
well.
then. Bye.
Take care.
Stop recording. There we go.